First of all, I'm just really excited. We have a group of great people here who are very entrepreneurial and helping us think about some of the out-of-the-box and different ways that we're thinking about population health or moving to value-based care. So thank you so much for coming. And I'd like to acknowledge Amy Flaster, Dr. Amy Flaster, who's on the slide, who was unable to attend today, so I'm in her stead, but she has spent a lot of time and knows this panel very well. So we'd like to acknowledge her and the work that she did getting ready for this. So anyway, so let's go ahead and get started. And again, we'll look at the questions. Hopefully we get some really great questions. We have some questions we've thought about a little bit, and we'll go through those, and hopefully we'll go where we are. If there are burning questions at the end too, we have some mics here. If you do get up and ask a question, Mike, please share your name and where you're from. That would be great so we get an understanding. So why don't we start with just maybe going down the line here, talking about, a little bit about what you do and what your organization does and how it really ties into population health and how your organization really thinks about care delivery with the patient in a novel way.
Great.
Do you want to start?
Sure, I'll start. It's very nice to be here this afternoon, and there's been such good energy, I think, throughout this conference that we were excited to be part of the Health Catalyst family this year. So thanks for having us. So my name is Lissy, and I started a company a couple years ago, and it was a venture-backed company. So we raised, a couple $1 million from some of the Silicon Valley investors. And then we were acquired just a couple years ago by a large publicly traded healthcare IT company, where I now, am part of that leadership team. And the focus of my company and what we were trying to do within population health was really think about population health, not just in terms of hospitals and physician groups, but post-acute care providers. So home health agencies, skilled nursing facility, hospices, LTACs, acute rehabs. What we were seeing is that as health systems and physician groups were transitioning to value-based payment programs, that a big component of their success was really around what's happening to patients in post-acute. People may not realize, but about a quarter of Medicare spend is post-acute, and it's actually outpacing hospital spend when you look at the rates of growth. I mean, just think about aging demographics, the silver tsunami, and think about all the pressures of hospitals to discharge patients earlier and earlier and earlier. And so where do they go? They go to nursing homes, they go home with a visiting nurse or DME or all those sort of ancillary services. So today, we've grown exponentially since I founded the company. Today we work with something like 1,000 hospitals and 20,000 post-acute care providers. We see something like about a third of the discharges coming out of the US hospitals into these post-acute settings. And so a lot of what I think about in my job is how do we think about population health, not just in terms of the risk-bearing entities like a health system and a physician groups, but really all the partners that they, as a hospital or health system, need to get on board to really be successful in population health. I'm sure a lot of you out there implementing your pop health programs, and you know that it's not just what goes on in the four walls of the hospital or the clinic, it's really sort of all those other constituents that you also need to get their buy-in and work with and collaborate with in order to be successful.
Great. Thanks, Anant.
Thank you. Just to echo what Lissy said, thank you to all of you for having us. I'm super honored to be sharing what we've learned at Virta, as well as what I've learned personally, working at this company and working on strategies to help drive population health forward. So thank you all once again. My name is Anant. I am an internist by training, and I currently work at a company called Virta Health. And what Virta does is, Virta is an online specialty clinic that focuses on treating patients with type 2 diabetes. And so we operate as a fully licensed medical provider. We're licensed in all 50 states, and we deliver a medical nutritional intervention that is successful in actually reversing patients' diabetes in 60% of the cases. And so when I say reversing diabetes, or what I'm referring to is patients are actually able to get their A1C below the diabetic threshold while simultaneously reducing medications. So at Virta, I wear two hats. I am a Virta physician, so I have a panel of patients that I take care of. And then I also lead our clinical technology development. So I'm helping to build out our operating systems that enable us to deliver this very unique care delivery model. I'll also highlight that everything that we do is 100% virtual. So we don't have any physical clinics. We don't have any in-person infrastructure. Everything we do is remote. And we have physicians and health coaches who are delivering this very unique type of care and doing so efficaciously. And I think from a population health perspective, what we're doing at Virta is answering the question, what if we could build a healthcare system from scratch with population health in mind? A lot of us today are facing the challenge of trying to have to retrofit population health strategies onto an existing episodic in-person based system that's also tied to fee-for-service payment. At Virta, we take payment on a fee-for-outcomes basis. We don't have the in-person infrastructure that we're tied down to. And so we can really ask the question, how should we design an operating model with population health in mind from the get-go? At Virta, we partner with self-insured employers and health insurance plans. We get paid on a fee-for-outcomes basis, so we don't get paid unless patients actually improve their health as it relates to their diabetes. And we've done this successfully in thousands of patients, and we're growing aggressively over the course of the next couple of years. I'm looking forward to sharing more about what we've learned and how it can help all of you.
Azalea.
Hi, everyone. Anyone here from North Carolina? Woo! All right. I'm Azalea. I would describe my role over at Duke Health, so the Dukies are in the audience as well, at the intersection of health data science, analytics, and with our intent to improve health, but also to enable the business, pop health, ClinOps strategy for value-based transformation. My two goals at Duke Health were around what is that strategy that would support our value-based contract performance. As you might know, New York Times has highlighted, it's really hard to keep up with the magnitude and pace of change in the state of North Carolina for many reasons related to both changes in our commercial market as well as with Medicaid. My primary goal for Duke was, how do we establish that core foundation of capabilities for such a large and complex organization? I would say that my specialty in that was really trying to help everyone articulate the right question that we're asking of the data to then advance our strategy in order to adapt to these changes. The other big goal was to show everyone what's possible or demonstrate what is actually possible. And when the stars align, so we are very lucky, we have really passionate, smart, motivated folks on the university side, the School of Medicine, and the health system who really just want to improve health for the populations across our state. And how do we get them to align? How do we do that hard, really intensive team-based science to show what we could do together? And that also includes, I send it to partners, including vendors. And we're not fundamentally designed to do that today. We've never been paid to do it that way. But the fun stuff we got to do, I was clinical lead for applications of fancy models, whether they're machine learning or NLP, into the workflows. I am not a data scientist. I'm not going to pretend I know. I know probably enough to be dangerous, but I know what it means to pull together these teams and kind of get them over the finish line so that we actually see that we're generating actual data and we're putting it into a workflow that works for our clinically patient-facing teams. I think the more important perspective I bring is I am a primary care provider. I serve a patient population that's complex. I work with a multidisciplinary team, and a lot of the issues that we encounter that are barriers for good health are around behavioral health, substance use, social determinants of health, and then I have been the clinical lead on efforts around advanced care planning and serious illness planning in the primary care space. In that role, I struggle with access to actionable data to enable my workflows and our teams to do what we need to do. It keeps me grounded in the reality of things. There's a model that'll fix everything, and then there's my life of clicking and trying to just get anything done. But it also makes me constantly wonder, what is it that we need to do to better enable alignment and transformation and the fundamental mismatch of the jobs that people need to do to get us there and what resources we've given them. And so now for exactly 1.5 weeks, I've been over at Blue Cross Blue Shield. That's about as long as I've spent trying to get here from North Carolina. And so the questions I ask are kind of what should a new generation of payer-provider partnership look like? And what is like the promise of data analytics to get us there, to really enhance what I think is always going to be a uniquely human experience. And then what is it that I can do or Blue Cross can do to enable the innovators to be a part of that, because we can't, there's plenty of work to be done. There's too much work to be done for any one organization to do it alone. So that's a very broad view of a big problem, but from kind of the vantage point of a provider, from a clinician, a provider, and actually now hopefully from payer.
Thanks. As you can see, they have some very unique and different experiences they've gone, and it's been, Anant, I think, talking about what would this look like if we started from scratch, I think was a very interesting thing. One thing we know is there's not a single definition for value-based care. Although most of us know what value-based care is, we think about it differently when we come from different perspectives as we think about population health. Some of you started to share this a little bit, but as you think about it from your perspective of shifting to value, how is your organization thinking out of the box as you're thinking about that value equation? We heard a little bit from Anant, but Anant, do you want to start?
Yeah, would love to. So, as I mentioned at Virta, we've had the benefit of being able to build a health system from scratch. And so from the get-go, we made a decision as a company that we wanted to get paid for outcomes and not to get paid for simply delivering a service. And so that initial alignment helped quite a bit. And I think the payment model is one of 4 elements that I think are really helpful in enabling us to build this new health system successful. So I think there's 4 elements. One is having the right payment model. The second is having the right technology model, and I can speak more about how our technology works to support what we do. The third is having the right operational model. So this is how are we actually delivering care. In our case, we're doing so via telemedicine. And the fourth, which I feel like doesn't get talked about enough, is the right organizational design, which is really talking about who are you hiring, what seats are they sitting in, and how are these people talking to each other. And I think that really is the combination of those 4 elements and how they all coordinate together is what enables us to be successful. And I can speak to any one of those in more detail, but at a high level, it's those 4 things. It's the right technology, the right operations, the right payment model, and the right organizational design. Those 4 elements together are what enable the promise of value-based care to be realized.
Great, thanks. Lissy, do you have some thoughts?
Yeah, I think, so as part of my job, I have the opportunity to visit a lot of hospitals and see how they're operationalizing a lot of these value-based payment programs, whether it's bundles or ACOs. And a lot of, and every health system thinks that they're a snowflake, which they are, because healthcare is still very local. But it's interesting because I think we're in this very, very unique time in terms of the evolution of healthcare. I think someone famous once said, like, the first 10, people always underestimate the pace of change and overestimate the pace of change in the first 10 years, but then the next 10 years, people always sort of underestimate how quickly some of those things are changing. And what I'm seeing a lot is that, people may be in these different payment programs, whether it's bundles, ACO, or now we're seeing a lot of contracting specifically with Medicare Advantage on value-based payment models. But a lot of these health systems that I'm working with, they're thinking about the future as more than just a health system. They're thinking about it as potentially a payvider, and they're trying to figure out, in what model can I really be successful so that I can build that bridge to the future. So they're experimenting with these programs, but as they're sort of doing all this experimentation, you have like a care coordination program for diabetes, you have a care coordination program for bundles, you have a care coordination program. So it's like there's a lot of experimentation going on, even within one particular health system. And I think that can be really challenging sometimes because you have to figure out when is the right time to consolidate all of that so that you have streamlined analytics, streamlined care coordination practices across all those different patient populations. You don't want to treat different patients differently. On the other hand, how much on the other hand, how much natural experimentation do you let people do to kind of figure out what really works for that particular payment program or that particular patient population? And so what I'm seeing a lot is that in the health systems that I'm working with, that there's just so much piloting going on, and it can be both a blessing and it can be a challenge for the administration. And I'm seeing this even outside of their normal operations. So they may own a physician group or be affiliated with a physician group, but then you have to bring all these other, like in our instance, post-acute care providers who are still on a fee-for-service basis, who still get paid a daily rate, and how do you get them to align? One way is maybe you vertically integrate and you say, I'm going to buy up all these post-acute care providers and they're going to become part of my IDN. Other people are saying, there's partnerships, and so I'm not going to buy everyone up, and so I need to figure out a way to partner with them, and how do I sort of align incentives like that? And so, it's an interesting time. I mean, I think and I think each health system is trying to really find the balance between, experimentation, because that's positive and that's how you figure out how things work, and then consolidation, which is how do we streamline and scale some of these programs so that we don't have these, care coordination silos across all these different areas of my business.
Yeah, it kind of reminds me of Anne to talk today about all the silos.
Right.
And one of the challenges is how do you tie those silos together, which you started talking about. There are different options as we go through that. So I think it is an obstacle for us all to work through. So.
Yeah, and what I see in what you said, Lissy, is an example of organizations investing in singularly one of these elements, right? People are investing solely in the payment model. Like in a previous life, I worked at the population health group at Partners Healthcare. I think they're going to be speaking more about some of their more recent efforts tomorrow, but I worked with them back in 2014, and there was a tremendous focus on negotiating these value-based contracts with Blue Cross of Massachusetts and other local payers. But once those contracts were in place, there was very little investment at the time in the technology model, the clinical model, and org design, and that just resulted in some additional work that needed to be done to make this all happen. So I think for me, the take home really is you need to invest in all 4 areas in a coordinated and simultaneous fashion for this to be effective.
Azalea, do you have some additional thoughts?
I would say, drawing from this morning, a lot of the common themes, but I think I've seen a lot of folks say, oh, it's a straightforward formula. You know who your attributed patients are, hit your quality marks, and then know what the expected total cost of care is and then what your actual is. And it's been a blessing, I think, that there's been this rapid change in payment reform in North Carolina. As a physician, I practice in a payer agnostic way. Your insurance status does not change what I necessarily do for you in the way it is today. But the movement has made it such that the vast majority of our patients are now part of these contracts. It becomes more feasible for us to take a moment and say, so what does value mean to us? And so we did this exercise. It's taken, my DUCAT, and it draws a bit on that, like blowing up that iron triangle that was referred to this morning. Outcomes that matter to the patient. Quality, meaning the right team, right care, right time. Patient experience, you're a valued customer, and so when we do partnerships, it should still feel like we're all in, that this is one cohesive experience and not this like continued fragmented situation that unfortunately our patients still are uniquely positioned poorly in that scenario. A huge part is clinician experience. We can't do this work without the wonderful providers, and we need them to stay and find that joy of work again. And then lastly, yes, we need to understand the total cost of care, but I think traditionally we've kind of treated that as zero sum, and it's every now wonderful innovation that we think about, we have to understand how it impacts any of those pillars or buckets, whatever you want to call them, but be very explicit about how we both measure them and also what the downstream effects are. And so I would say that to the credit of Duke Health System, spurred though by all the changes around us, those kind of honest conversations are happening.
That's great. Thanks. I think we talked about a couple of these, but in your experience, what is the greatest obstacle provider organizations are facing in this shift to, from fee from service to fee to value? Anyone want to jump in?
Your turn to go first.
All right, I'll go first. I think I'll build on a point Anant made. I think that the obstacles are very much around this mismatch of the job, or one, articulating what are the jobs then that need to get done in order to provide value to our population of patients, and are we fundamentally designed as an organization to deliver on that? And so how quickly can we figure that out and do this? Because we're planes in the air and we're having a whole new aircraft and we got to land this thing. I think that's the biggest obstacle of just, in the meantime, we have a pretty full hospital. There are people who still need our care, and you're trying to still make sure that the things that you do right continue to go as planned while you're trying to build for the future, and that's incredibly challenging for these big, complex organizations. And so there isn't the luxury of building from scratch. At the same time, there's a role for everyone in this, and that's, I think, the largest challenge, and a big part of that is we don't have all the same view of the same problem together, and that gets to another point from this morning's sessions around the silos of data. Hopefully, payer-provider partnerships will help to some degree. I'm excited about other sources of data too that tell us a lot more about our patients and what they need and how we can better serve them. But until we can all pull that together and do it, integrate the data and have it rapidly available for us to actually act on it in a reasonable way, I think that'll be one of the biggest challenges.
Do you have any thoughts, Anant?
Yeah, I totally agree. And I think my thought on why this is so hard has more to do with the fact that there are just certain realities about measuring value in healthcare. And I think my personal view is the reason why we have a fee-for-service system is not because a cabal of health system executives got together decades ago and were like, how do we make the most money? I don't think that's what happened. I think it was a very rational outcome of, I think, a few realities about measuring value in healthcare. So what are those? Number one, it's hard to agree on what value actually is. Meaning, how do we define, for something like prostate cancer, right? How do we define what value is in that context? Is it the fact that we've eradicated the disease, or is it the fact that we've created a situation where the patient's free of side effects, like incontinence? Those two can be in conflict. So it's hard to define value. The second thing is, even if we can get to a point where we can define what value is, it is hard to actually wait for it to accrue. So many of these measures can take years, if not decades, to actually accrue. So if we're defining value in the context of cardiovascular prevention as a heart attack or stroke avoided, that can take upwards of a decade to accrue. And so you're looking at a long time horizon to actually measure value from that perspective. And the third is that even if you can check off those first two boxes, how do you actually attribute the value? And I think this is something that folks who are deploying solutions now are running into, is who gets credit for that total medical expenditure reduction? Is it the innovative primary care model? Is it the case management model? Is it the new med management solution? How do you actually attribute value? And so I think why this is hard is really a fundamental reality of why measuring value is hard in general in healthcare. Now, I'm optimistic that we'll get there now, because I think we have the tools, we have the technology, we have the people, we have the policy changes to make this all happen. But I think we should, I sometimes feel like we're too hard on ourselves as a healthcare system, that we have this fee-for-service system, and I think that it is actually an outcome of some fundamental realities about just measuring value in healthcare.
Yeah, I think a lot of the challenge relates to the fact that we are in this period of transition where, we still have fee-for-service contracts, we have, increasing value-based payment contracts, but even those value-based contracts look very different, whether they're with Medicare or they're with the state or they're with, a commercial payer. And so designing programs that can check off the boxes to be successful across all of those very different contracts, I think, is challenging. How do you prioritize your limited resources to be successful at, any one of those contracts? And, I can say that even with some of the post-acute care provider and the strategies that I've seen the health systems that we work with embark on, they look at the data and they look at, in the Medicare population, for example, about 3/4 of variation in Medicare spend is attributed to differences in post-acute utilization, which is crazy. 3/4 of the variation is attributable to things that don't even happen in your own hospital. So how are you ever going to be sort of successful in some of those contracts, right? And so then they start to look at the post-acute care providers themselves, comparing the different skilled nursing facilities, building a scorecard, and they find that you can't even say that the good ones are good for every patient and the bad ones are bad for every patient. Some are really great at taking care of heart failure patients. Others are really great at taking diabetes patients. And so, what are you going to do with that? And at the same time, you have to make sure that there's enough access, because if you only limit it to 3 good nursing homes in your area, where are the rest of your patients going to go? And so I think there's so much nuance right now and thought that needs to happen, from sort of the strategy and contract terms all the way down to the operations, that you need to have really good people who can do that translation for you. So even, as you were saying, even when you go out and get the contracts, you make them favorable, you think you can achieve them, who's going to then translate all of that down to sort of the way that care is getting redesigned. And that translation process, I think, is very difficult, especially given all the competing priorities within a health system. I do think that's one place where data can really help, because obviously you only have limited amount of time and resources. And what data, I think, is really good at is helping you figure out what are the highest priority areas of which to focus, because any given team can only probably focus on like 3 things to really be able to execute at 100% level.
I would just like to build on the point. I think that highlights 2 other areas that are huge obstacles, I think, are around communication and culture. I would say if you walked out into any of our clinics and tapped someone on the shoulder, it's like, do you know how we define value? And they'd be like, I'm sorry, I'm incredibly busy. What are you doing? But I don't, there's a lot that maybe everyone here in the room pays attention to, and then there's the real world where this is just, and that, how to message and help people understand what their role is in that is incredibly challenging. And there are obviously issues of culture and that kind of permeate that obstacle as well. So I don't have an answer for it, but I think that is another one that doesn't maybe get as much attention.
Yeah. I think you brought up the idea of data and analytics. I'd like to hear some additional thoughts about how have you best seen data and analytics supporting your journey or the journey in population health? Want to start or not?
Sure. So I think how we've been successful, so I've talked a little bit about the payment model, the fact that we're fee for outcomes. But I think another aspect of how we've been very successful is how we've integrated analytics into our workflow. And I think thinking about workflow is so important when it comes to actually making these strategies successful. And again, the fact that we're starting from scratch has given us an advantage in that respect. So just to be a little bit more specific, we have algorithms, we have risk scores, we have data science, machine learning models that are trying to identify who among thousands of patients our physicians should take care of, or who they should focus on at any given point in time, right? So we have thousands of patients under our care, and our physicians have medical legal responsibility for all of them. But it's impossible for them to look at every single piece of data instantly as soon as it comes in. They have to prioritize. They have to figure out how best they're going to use their time. This is a universal problem in clinical medicine. But what we started with as we started to solve this was, let's not build the model first. Let's understand the workflow. Let's understand how providers are actually going about this process of prioritizing patients and actually intervening, and then actually build out a solution. And so what we have is a model that will prioritize patients and help physicians understand global risk of their entire population. I mean, this is really true population health, but it's done in a way that deeply integrates with their workflow. And I think the contrast I'll draw is, when I was in residency, we had a group that developed a really effective, really great risk scoring model that was looking at their readmission risk. But there was very little engagement with the providers on how this would actually be used in workflow. And the way this was deployed was kind of on our Epic dashboard as like a readmission risk score. And I remember the first day it was rolled out, I opened up Epic, and every single patient on my list had like a 95% risk of readmission. And I was like, what do I even do with this, right? I mean, the model was probably correct, right? Like, it's probably true that a lot of those patients had a 95% chance of being readmitted, but as a physician, I did not know what to do with that information. And that's where it's so, so important to think about the workflow and start with that and then work backwards to the actual model. I think there's no shortage of models and analytical risk scores and whatnot, but what's really lacking is the ability to actually do something about it. And that's where the workflow piece is so important.
I think the example I can give is around our efforts around advanced care planning, serious illness planning on a population basis, with the effector arm being your primary care practice and that therapeutic relationship you have with your provider there. But knowing that I myself cannot do these 30-minute really intense conversations in a workday, I need help, I need a patient navigator to help, we can do this together. We figured out what that workflow would look like first before we then said, okay, now who do we invite first? And we should have their family come too. In a pilot that was rapidly successful, our patients really appreciated the opportunity to be able to do this, brought their family. We got a lot of power of attorney documents done, a lot of goals of care conversations documented in Epic. Was driven first by, I think the data science was supposed to be like business rules. Like, it was about your comorbidities, whether or not you've been in the hospital in the last, how many times last year, and your age. And we asked PCPs, like, hey, we generated this list of people. Anyone here you disagree shouldn't have a opening advanced care planning conversation? And they said no, and if they did, it was for reasons that probably aren't appropriate, like this person has advanced dementia, well, that just means we didn't do this early enough, or this person has language barriers, that's not a reason not to do it. We always knew that there was gonna be a better model, but that the hard part was proving that patients want to do this, their families want to do it, and that we could measure the impact of what we were doing. And that last part is a little hard. I don't think we do a great job in thinking what that evaluation plan looks like, what the implementation plan looks like, what the evaluation plan looks like, and then what scale looks like. But we started first with what is that workflow? How are we going to implement this? Who's going to do? Whose job is it? And who's measuring? And how's that going to feed back? And then the model told us where to start. And I could. That speaks to my heart and my microphone.
Thanks. Lissy, Ania?
Yeah, I think what we're all coalescing around is, in some ways, you have to start with the answer first, which is, well, if this data shows X, like, what are you actually going to do about it, right? Like, how's that actually going to change workflow, management, decisions that are being made? So how is this data actually going to be actioned upon? How is it actionable? And I think as physicians, as technologists, our natural bias is to build. And I think in healthcare, at least, sometimes less is more in terms of if you can approach it from the end, that will help you better understand what exactly is the question that you're trying to answer. I do think that analytics, you have to approach it with a lot of humbleness. To Anant's point of, you build your algorithm, you run your C-stats, everything looks awesome, and you're like, this model is great, and then you put it into the physician workflow, and then everybody has, a high risk of diabetes. Everyone's going to die at some point, right? So there's a little bit of that, and we had a similar experience implementing some risk models in the post-acute settings. And we thought these models were great, and then again, it was sort of the same issues where everyone's sort of at risk, so then you can't, what do you do with that? Because if everyone's in the risk population, are you going to deploy your intervention across everybody? That's just not, maybe with enough time and resources that's possible, but in most cases it's not. And then when we dug into the data a little bit more, what we were finding on the nursing home side was that a lot of the predictors of readmission that we were seeing on the ambulatory acute side, like diabetes, heart failure, and a lot of those comorbidities, what was actually more predictive in the nursing home setting were things like inability to swallow, things that were very functional, inability to ambulate, bed bound, and we could have gotten a lot out of that even just by talking to some of the clinicians and folks in the skilled nursing facility. So I'm sure a lot of folks in the crowd are, lovers of data like us, And I think some good lessons that I've learned over time is obviously figuring out what question you're trying to answer by figuring out what's actionable. And then before you go and run into your models and do this and that, really just starting to investigate the workflow and talk to the people in those settings and, be humble about your approach to data analytics.
It sounds like it's a reiterative process where you're going back and checking before you go too far ahead.
Yes, exactly.
Good. I'm going to ask a couple questions. There's a couple that have a lot of popularity in the audience. They're around virtual care. I think, Anant, you talked about this, and maybe you have some experience too. But a couple questions. One is, a lot of times, particularly in population health and with some populations, they are not technology savvy. So the idea of virtual care is one of the questions on what is your learning around the use of patients or individuals using that? And then the other big question came about is, how did you train providers and those folks that were supporting that process in the virtual care? So I think they're thinking about a couple barriers that could potentially happen.
Yeah, those are really great questions. I think for the first one, which is how do we make this type of access to care something that's achievable or accessible, frankly, to a broad spectrum of patients. I think the one learning that we had is that a lot of our assumptions about patients not being able to use technology, elderly not being able to use technology, low socioeconomic status patients not being able to use technology, at least in our experience, are wrong. We treat a broad spectrum of patients who span from Silicon Valley venture capitalists who are biohackers and don't have any illness and just want to try Virta out, all the way to people in their 70s who are bedbound and have a BMI like above 80. And they all equally respond to this therapy. Like, we don't see any difference in age or anything like that in terms of, basically across any of these classic segmentation dimensions, we don't see any difference in our population. I think what that speaks to, I think, is the responsibility that we have as health systems and providers to actually try to meet people where they are and to kind of set our assumptions aside and to treat people as human beings, as though they were like part of our family, right? I mean, we all have grandparents and folks who you might not automatically assume can use technology, but because we care about them, we make the effort, and more often than not, they're able to use it. And I think we just need to make that same effort. And I think the question, of course, is going to be, how do we do that? How do we scale that? And I think that's the hard part. But we're figuring that out. But I think the first thing is just set those assumptions aside. Don't assume that we can't do this because these patients are too poor or these patients are too old. Like, do not assume that. That is just setting it up for failure. The second question around how to train providers in virtual care, I think, is a really good one. This is a new way of delivering care. There are many things that should be taught in medical school that are not, as we found out this morning, but virtual care is not currently being taught in medical school or in residency for that matter, and it is a very different skill set. It is a very different way of delivering care. You have a more limited set of inputs that you get about a patient. You have to establish that connection using a different medium. And I think what it starts with is really finding the right people, and I think that's what we've been really thoughtful about, is trying to find providers who are really interested in changing how they might want to deliver care and do their work. And then I think that's kind of where we are right now, to be honest, is like we're still kind of figuring this out. And so it's really about finding those right people who are willing to learn with us and to help define the operating system. And then, in 5 or 10 years, we'll have defined best practices and we'll kind of have a good, robust set of principles that we can translate across the board. But I think right now, the most practical advice I would give you is really invest a lot of effort on the front end to find those right individuals who can be a part of your effort. Don't invest in the administrative hospice people that we talked about this morning. Like, really find those 20% who are already bought in and have them run with this.
That's good. Did any of you, this is another question that's come up a lot too, have used technology in population health, and do you have any examples of success in using technology? They're voting secretly behind it.
In terms of successes of using technology in pop health, One area that we've had a lot of success in is leveraging, I think there's a lot of great analytics out there, and of course we're leveraging analytics, but one of the things that has been newer for us is leveraging real-time information to power some of the care coordination pieces. And so, you know, claims data, for example, is a really rich source of data, and in some ways, you know, it's sort of the standard bearer of truth, but because of some of the lags and stuff like that, it's difficult to create action and care plans around some of that. And so one of the things that we're seeing a lot of our health systems starting to do is they're getting real-time data from other EHRs, trying to track where their patients are, especially in areas where there's a ton of leakage. And so then in their care coordination tools, they're adding in more and more real-time data so that the people, the frontline staff, it's not just the population health suite is becoming more and more not just an analytics suite for administrators, but how do you take some of that data to the frontline staff who are doing the care coordination on a daily basis, so that they can even answer questions like, instead of getting on the phone and calling around and trying to figure out even where their patients are, so they can get some real-time alerting around, hey, a patient showed up at this ED, now what am I gonna do? So more and more, that's sort of what we're seeing, is the pop health suite sort of bleeding more and more down to the frontline users, which I think is a positive trend overall.
I'm sure there are a lot of successes, but I would venture to say that I would still call them pilots. And I think this is the part back to where we all started around, are we fundamentally organized around the ability to accept and fully harness the potential of a technology for a population of patients and make this kind of work for everyone in a systematic way. Also get rid of things we know they're not working. And I think those are the hard things to kind of do on the fly when things around you are evolving so quickly. So and also I'm speaking from a vantage point of a academic medical center where there's a lot of innovators that are very close to their clinical pain point or administrative pain point, and they have effectively used technological solutions, analytic solutions. But then what that means for the enterprise and how we are all graded together as a whole is still a little lumpy. And so I think that is my diplomatic way of saying that there's a little bit of really good pilot. How do we get that to scale? And when it's at scale, I'm be willing to say, yes, we did that well.
That's great. We still have a long way to go to learn in this area, it sounds like. And the other area that there's a lot of questions are the fee for outcome. Mm-hmm. Questions around who defines the outcome measure, some around the contracting piece, and just maybe share a little bit more about how that works, where you've seen some of the successes and where you've seen some of the challenges actually.
Absolutely. So I talked before about the 3 reasons why value is hard to measure and kind of get paid on in healthcare. I think in the case of diabetes, we're actually fortunate in a few specific examples. So one is we actually do have a measure that's generally agreed upon as a marker of value in diabetes. That's the hemoglobin A1C. It doesn't take that long to measure. You can measure it every 3 months and see meaningful changes. And then in the case of our intervention, what we do is so different from what the conventional healthcare system does in terms of standard management of diabetes that the attribution is relatively, well, we'll see about the attribution piece, to be honest, but in theory is easier to do. So I think, to be honest, we're very fortunate in that respect. But I will say, though, that we need to figure this out as a healthcare system. I don't think that, I think Virta can and will be very successful, but I don't think our success is going to be sufficient to transform the healthcare system in the way that you might say, oh, well, Amazon alone can be successful and can create a collectively better retail experience. I don't think our success is going to be enough. My hope is that what we can do by being able to build something from scratch is that we can create a playbook and some models that people who are trying to do this in the existing system can learn from and can benefit from. And so I think that from a contracting perspective and in terms of how we all figure this out together, I think it's about looking at where this has been successful, and I hope that at Virta we can do that and kind of see what we can learn, and then try and translate that to other conditions, to other contracts. And it's going to be messy, and we're kind of figuring this out as we go along, but I think having those early wins, and I hope that we can be a part of that, is going to be so, so helpful. Because otherwise we're just kind of stuck where we have paper after paper coming out that says there's no difference in outcomes for ACOs and this, that, and the other thing. And I think we just need to have those early wins. And I think my hope is that at Virta we can be a part of defining that.
Great, thanks. There are a lot of great questions, so people might be coming up and asking you some really great things. Just in the last few minutes, I'd like to ask each one of you a couple things. One is, what are the trends that you're really excited about? And maybe even some of the companies that you're watching closely as you think about who are doing some innovative, kind of out-of-the-box thinking. Lissy, do you want to start?
Sure. I think, and I know there's been a lot of discussion at this conference, but I really do think some of the things that we're seeing around machine learning, NLP, AI is incredibly exciting. I mean, just the ability to take all of this healthcare data and surface insights that you may not, because you have your own biases and you have your own assumptions, and being able to kind of be clear of that using technology, I think that's really exciting. I think that on the AI side, from a clinician perspective, being able to manage increasingly by exception rather than on, having to sort of treat every patient the same way. Those are some of the things that excite me. But AI has probably a lot of the pitfalls that we've also talked about with respect to analytics in general is, how do we make sure that it's actually actionable, that we trust it, and that it augments physician care rather than supplants clinical thinking and patient care and sort of that, those touch points.
So I think I'll say something that maybe is sort of boring, which is I think telemedicine, which I know has been around for decades now. I think telemedicine to me holds the most promise. And I think my reason for saying that is that I think we're finally seeing the alignment of the technology, which is telemedicine, with the operational models and increasingly the payment models. Like, meaning that we're now having ways, as we heard about this morning at Jefferson, where we actually have the delivery models to really fully realize the potential of this technology. And we're soon going to have, I think, payment models that support the use of telemedicine as well. So I think telemedicine is going to be quite transformative in the next 5 or 10 years. And I think that in terms of companies that I think are interesting, I'll kind of pivot and talk about things more in general. I think, just to list off a few, I think in kind of the general analytics and service provider space, I think Aledade is super interesting. I think that we need to find ways to bring all providers into this value-based transformation, and I think Aledade is doing an outstanding and very unique job of engaging community practices and rural practices and helping them be a part of the value-based transformation, leveraging technology. So I think they're super interesting. From a payer perspective, I think what Blue Cross Blue Shield of North Carolina is doing is very interesting, more so, in my opinion, more interesting to me than these technology-enabled insurance companies like Oscar or Clover or whatever, because I think what Blue Cross is really doing is aggressively investing in value-based transformation, lots of different partnerships with interesting companies, and it'll be an interesting process, but I think they're definitely a group that I'm keeping my eye on. And from a provider perspective, I think Iora continues to be very interesting to me. I think they have this great alignment of, again, operating model, payment model, and organizational design. So those are kind of 3 companies that I'm really interested in.
Thanks.
Thank you for the shout out. And part of the appeal of this new position was to be able to work with these amazing, awesome, innovative companies. So I would say for first on my list, I'm excited for social drivers of health, social determinants of health, how you call it. I'm just glad you're talking about it. And Unite Us and their product NC Care 360 is to credit the vision of our Secretary Mandy Cohen in North Carolina. What is it going to mean when we suddenly have social determinant of health data for, let's say, for the Duke Health System of 80,000 patients? How will that influence the analytics we can do to better understand what we could be doing better to meet their needs and to actually improve health? I think it's incredibly powerful. And what I love about them is also part of their solution is about changing the front door to health. It's empowering barbershops and churches and community organizations to who have a very, very important place in the health of populations to be able to act on data and also contribute data. And I think that is in my heart of hearts, where I think that there's a great opportunity. I'm obviously biased to a lot of the amazing companies that Blue Cross is working with. I am an intensive primary care fan. It's sad to me that I look at the Ioras, the CarePorts, and the city blocks of the world and say, and I also am a fan of Allday, but I see those models and think to myself of my complex patients and where my model falls short because we're retrofitting it into a complex or older organization versus what they're able to do for that same patient, building from scratch. So excited to see where that goes.
Great. Well, thank you so much for participating. Thank you for asking great questions. And I think we're going to learn a lot. I think this morning, we learned about how do we put this all together in silos? How do we think about bringing in some of the community aspects into this? And excited to hear next year where we're going to be. So I'd like to turn a couple moments over to Josh, right?
Yeah, thanks. So I think we got 2 minutes left. If you guys wouldn't mind just filling out, going into the application and putting in some reviews. We'd like to thank the panelists and as well as our moderator today for the great discussion. I know I've learned a lot. I hope you guys have as well. Let's just give them a round of applause.
Thank you.